Malignant melanoma, the most serious skin cancer, the most serious, dangerous, fatal skin cancer, malignant melanoma. But I have first to start with the benign lesions in order not to make you panic. Not all skin nevi are malignant. Actually, most of them are benign, as we see in this picture. What we call the junctional intradermal nevus is a benign lesion. Distinguishing between benign and malignant skin lesions is by the shape and color. Shape and color of the lesion. Look at this benign lesion. Benign lesions in general, they do not grow in size. At least they do not grow very fast in size. And they have smooth, regular borders. And their diameter is usually less than 1 centimeter. And they are homogeneous in color, either dark or pale. But I mean they are homogeneous, dark or light color, but they are homogeneous. The color remains constant all the time. But still, biopsy is the most accurate method of making a diagnosis. Is it really benign? Is it really malignant? I cannot tell until I have biopsied the lesion. And we remove benign lesions. What's the indication of removing a benign nevus? Only for cosmetic purposes. Of course, if your insurance is gonna provide and pay for that. But malignant melanoma, there are gonna be some changes that will tell you, hey, it seems that your benign lesion is no longer benign. It's transforming into malignancy. How did you know? It grew inside. So the tumor, too much growth in size. Malignant tumors will have irregular borders, will be uneven in shape, non-symmetrical. If you draw a line in the center, the two halves of the tumor, the two halves of the lesion will not look kind of identical. And there will be inconsistent coloring. Either the color is going to be too dark or too light. It changed, the color changed. The only way to diagnose malignant melanoma is full thickness biopsy. It's not just a biopsy. It should be full thickness. Why? Because thickness is by far the most important prognostic factor. The thicker, the deeper the malignant melanoma, the worse the prognosis. The treatment is, of course, excision. Interferon seems to reduce the recurrence rates. So our case study is about a 38-year-old male who presented to his primary care provider after his wife noticed a suspicious-looking dark brown mole in his scalp. So, what are the risk factors for melanoma that this patient has? Two risk factors, actually. Several blistering sunburns as a child, and the combination of fair complexion, red hair, and light-colored eyes. All these are kind of risk factors. Notice, risk factors are not causes. Risk factors are not causes. They are something associated with increased number of patients who have this malignant tumor. Why is the cervical lymphadenopathy especially critical to the prognosis of this patient? Because infiltration of the lymph nodes with melanoma cells will reduce the prognosis significantly. When there is lymph node involvement, the 10-year survival rate is only 30%. Wow, that's very low, very low. So we should always explore the lymph nodes draining this area. Are they involved or not? It has a very important prognostic significance. How might this patient be best treated? Excision. Since the thickness of that tumor was 3.8 millimeters, surgical excision of the melanoma with at least 2 centimeter margin is recommended. And the enlarged lymph nodes also should be biopsied and surgically removed if malignant. And since there is strong evidence that the tumor has metastasized to both liver and brain, the use of dacarbazine is an appropriate last resort option. So if there is metastasis, you need to use chemotherapy.